Welcome my dear students to the session of anatomy doubts. Shall we start the session? Okay. So question number 1. Pterygopalatine ganglion is functionally connected to. Options given here are facial nerve, mandibular nerve, glossopharyngeal nerve, maxillary nerve. Okay. Here the term is functionally connected. There is one more term called topographically connected. What are all these terms? Okay, look at this slide. Okay. So you can see there are black, green and red. These are nerve fibers. Okay. This is ganglion, pterygopalatine ganglion in the pterygopalatine fossa. Okay. So these red fibers arise from the greater petrosal nerve, which is the branch of the facial nerve, reaches the ganglion and synapse at the ganglion. This is very important. Listen, it synapses at the ganglion and gives postganglionic fibers to various glands. Okay. The fibers, black fibers, which are arising from the maxillary nerve, just pass through the ganglion without synapse. The green fibers arising from the deep petrosal nerve or sympathetic fibers just pass through the ganglion. Okay. The maxillary nerve is sensory. This has three roots: sensory root, sympathetic root, parasympathetic root. Only the parasympathetic fibers synapse at the ganglion. Okay, whichever fibers synapsing at the ganglion are functional fibers. Okay, so pterygopalatine ganglion is functionally connected to facial nerve, the greater petrosal fibers of the facial nerve. Okay, the maxillary nerve is topographically related. Topographically means it is just geographically present at that region. Okay, location. So question number 2. Clarify upper motor neuron and lower motor neuron facial palsy. Okay, look at this diagram. Okay, you can see the facial nerve nucleus in the pons, and above this is supranuclear, below this is infranuclear. Okay, or lower motor neuron or upper motor neuron. So Bell's palsy, what we know is a lower motor neuron palsy. In Bell's palsy, you know, if there is a lesion on the right side, the whole face on the right side will be affected. But when it comes to the upper motor neuron palsy, only the opposite side of the lower face is affected. Here see, there is a lesion on the left side of the brain. Only the opposite side lower face is affected. Why only the lower face? Can you see the blue fibers here? The blue fibers alone goes from right side, means it goes to the left side also. Left side also, right side also. Again, left side means it goes to the nucleus on the right side also and left side also. Okay, these blue fibers supplies the upper face. These green fibers supplies the lower face. Okay, see the green fibers reaching the opposite side of the lower face. Okay, so when there is a lesion in the supranuclear region, the lower face is affected. The upper face will not be affected as there is a bilateral representation. If this side is affected, the fibers from the opposite side prevent that function in the upper face. Okay, how you can check, differentiate lower motor and upper motor? If they ask, it's clinically differentiated by asking the patient to raise the eyebrow. Okay. Question number 3. In facial palsy, which muscle is paralyzed? It is orbicularis oculi or orbicularis oris. In lower motor means it is both orbicularis oculi and orbicularis oris, or both are affected as it is supplied by facial nerve. Okay, suppose if they ask, lower motor upper motor neuron, you can go for orbicularis oris. Okay, so fourth question. I am not able to grasp and read the various efferent and afferent distribution of the cranial nerves. It is basically a functional component of the cranial nerves. Okay, this, don't get scared by looking at this diagram. See, I'll try to explain in a simpler way, but it's confusing only. So, can you see it is motor columns and sensory columns? Motor means efferent, sensory means afferent. Okay, motor means efferent, sensory means afferent. These two terms you have to be thorough. Okay, so there is one more term you are seeing, somatic and visceral. What is somatic? Somatic means it's concerned with the external environment, like pain, touch, temperature, these are all somatic functions. Voluntary muscle movements, these are all somatic functions. Okay, I'll just tell what are the somatic functions of the head and neck region and visceral functions. Okay, just you have to remember this. Somatic functions are pain, touch, temperature, muscle movements and all. Muscle, when coming to muscle, it is efferent. When coming to the senses, pain and all, it is afferent. Okay, so what are visceral? Viscerals are muscle movement, which are the muscle movements which are arising from the brachial arches. Okay, the second arch muscle like facial muscles, the first arch muscles like muscles of mastication, these are all visceral in the head and neck. And taste, okay, this is visceral function. Okay, so and secretions of the gland, these are visceral. Okay, and remember general and special. Only in the cranial nerves we have special component. So we have 7 components totally. When concerned to efferent and afferent, it is 7. Okay, the other regions only 4. Only in cranial nerves we have 7 component. Okay, why it is special? Special means special sensations like vision, hearing and taste, these are all special. Okay, one more special is this brachial. How can you remember brachial arches? Is brachial arches are special to remember. Okay, so you can remember this special visceral efferent means, or brachial efferent means the muscles arise from the brachial arches. Okay, for example pain, temperature, touch. Okay, these functions are arised from trigeminal. Okay, these are concerned with the trigeminal nerve. Okay, these are afferent and these are somatic and these are general. Okay, so general, somatic, afferent is concerned with trigeminal. And one more thing, special visceral efferent, muscles of mastication are supplied by trigeminal nerve, right? And special visceral efferent component is also associated with trigeminal. And one more thing, come to the facial nerve, it is special visceral afferent. Taste is a afferent sensation and taste is a special sensation and taste is the visceral sensation. Okay, so it is special visceral afferent comes to the facial nerve. And all the secretions are parasympathetic and efferent, and all the secretions are viscera, so it is visceral efferent. Okay, general visceral efferent. Okay, salivatory nucleus and all come under the component of general visceral efferent. And somatic efferent, okay, voluntary muscles of the tongue, extraocular muscles, voluntary extraocular muscles, these are all efferent and it is somatic. Okay, just you have to remember the functions and the nerve concerned with that functions, so you can arrive at the answer if they ask. Okay, so look at this question. All the following nerve nuclei carry somatic efferent fibers except, okay, here the question is somatic efferent. Okay, so efferent means muscle movements. Okay, so all have motor component, right? Especially abducens and trochlear are purely motor and oculomotor is purely motor. So it has an efferent component. Okay, these are voluntary muscles. These all supplies the eye muscles, oculomotor, abducens and trochlear, all are voluntary. So what somatic I told? Somatic means voluntary muscle functions. What is special visceral? Brachial arch muscles. Okay, then brachial arch muscle means facial. Facial have special visceral efferent, not somatic efferent. Okay, I hope you're clear with this and you have to go through this again. Okay. So come to the question number 6. So the trigeminal ganglion is option A, a motor and sensory ganglion of trigeminal nerve. This option is wrong, as the trigeminal ganglion is only sensory. Okay, the Gesserian ganglion is only sensory. Even though the trigeminal nerve is a mixed nerve, the motor fibers joins the trigeminal nerve, but the ganglion is only sensory ganglion. Okay, and the trigeminal ganglion is made up of unipolar and bipolar cells. No, it is made up of only unipolar cells. Okay. Option C, look at the option C, it is homologous with the dorsal root ganglion. Yes, it is homologous with the dorsal root ganglion. So the option here is the answer here is the homologous with dorsal spinal ganglion. Okay, so is it the first order neuron? Yes, it is the first order neuron. You have asked what is the first order neuron. Look at this picture. So the sensation, nociception means pain sensations which are from the periphery from the free nerve endings reaching the dorsal root of the spinal ganglion. Okay, this is first order. From spinal cord to thalamus, spinothalamic tract is the second order, and thalamus to cortex is the third order. Okay, the detailed explanation of this pathway, pain pathway, and trigeminal nerve pain pathway will be explained in physiology class. Look at the question number 7. Vein of Galen drains into. Vein of Galen drains into straight sinus, but here there is no option of straight sinus. I think the option A is straight sinus, but they have wrongly typed as sagittal sinus. If there is no straight sinus, you can go for inferior sagittal, but if the straight sinus is there in option, you have to go for straight sinus. Okay, in this question they have given it drains into the confluence of inferior sagittal sinus and anterior extremity of straight sinus. It is quite confusing. They have confused it in the explanation. You don't get confused with the confluence of the inferior sagittal sinus and anterior extremity of straight sinus with the confluence of sinuses. Okay, that is different confluence. Okay, what they mean here is at the junction. Okay, confluence means at the junction of inferior sagittal sinus with the straight sinus, the vein of Galen coming and draining. That is what they may mean, not the confluence of sinus. Okay, so look at this slide. Confluence of sinus is formed by transverse sinus, occipital sinus, superior sagittal sinus, not inferior sagittal sinus, and straight sinus. You can remember a password called TOS for this. Okay. Look at question number 8. Which of the following structure is least likely to be damaged during mandibular third molar extraction? It's a straightforward question. Least likely is lingual artery, as it is present in the substance of the tongue. Okay, so the lingual nerve will closely go on the lingual side of the mandibular third molar. Okay, sometimes it may be very close, so even during the extractions it may be damaged. Okay, and during transalveolar extraction you may damage an inferior alveolar nerve or inferior alveolar artery. So sometimes it may be close, closely related. The canal may be closely related with the mandibular third molar. Okay. So the next question is suprameatal triangle externally represents. It externally represents. The answer here is the mastoid antrum. Okay. So look at this picture. So there is a triangle above the external auditory meatus on the surface of the temporal bone. Okay, so 1 to 2 centimeter deep to this lies the mastoid antrum. So it is a clinical, a surgical importance, where when you are performing the cortical mastoidectomy, you have to consider this. Okay. Question number 10. Internal thoracic veins are tributaries of the brachiocephalic vein. Again, straightforward question. So see, the other tributary which you have to remember very importantly is inferior thyroid vein and vertebral vein, which are also tributaries of brachiocephalic vein. Okay. Thank you.
Hello everyone. Okay, so I'll be solving a few doubts which you all have put across, mainly on embryology and anatomy. So let's start with the first one. So one student asked me a question regarding this MCQ. So muscles of the tongue are derived from which of the following? Now, in the process of embryology, it's very important to understand that there is something called a neural tube, right? Neural tube. Now when this neural tube is forming, on either side there are some collections of mesenchymal cells or mesodermal cells, and this collection of the mesodermal cells on either side of the neural tube is called the paraaxial mesoderm. I'm sure you all are aware of this in embryology. Now this paraaxial mesoderm will eventually separate into blocks of different cells, and these cells are nothing but our somites. Alright, now these somites are very important. They'll be mainly forming the vertebrae, the ribs, all the skeletal muscles of the back, the limbs, the body, and they'll eventually differentiate into what we know as sclerotomes, myotomes, dermatomes. So what are these? Basically, a myotome is a group of muscles which are supplied by a single spinal nerve. So similarly, like how we have dermatomes, an area of skin which is supplied by a common nerve. So similarly, we have myotomes. Now, most of the muscles of our body are supplied by these somites, and along with that there are two important myotomes which is formed from the somites, which will supply two groups of muscles in the head and neck. Very important to remember. The first one, we have the preaortic myotomes, which will form the extrinsic muscles of the eye. So all the extrinsic muscles, the recti and oblique muscles of the eye, are supplied by our option D, that is the preaortic myotomes, whereas the occipital myotomes, the second group of muscles known as the occipital myotomes, these myotomes are going to first be in the occipit. As you can see here, they are present first initially in the occipital region. They are about 1 to 5 in number. They'll be present here, and then they'll migrate downwards towards the floor of the mouth, and they will form the muscles of the tongue, and this myotome is innervated by the hypoglossal nerve. That's why all the extrinsic and intrinsic muscles of the tongue are innervated by the hypoglossal nerve. So this is an important thing to keep in mind. The MCQ muscles of tongue, like I said, are derived by the occipital myotomes. If a question is asked regarding muscles of the eye, the extrinsic muscles of the eye, it will be the preaortic myotomes. So this is the first one. I hope that was clear. Now the next question is that the primary germ layer endoderm is derived from. Now just focus on this diagram, and remember, you all know there's something called as gastrulation, wherein that is differentiation of the developing embryo into three layers, the ecto, meso and endoderm. Now how does this happen? First, I hope you all remember there's something known as the bilaminar disc. This was also asked to me by one student. So the bilaminar disc, which is formed during embryogenesis, is basically consisting of two layers, the epiblast and the hypoblast. So initially our embryo only has two layers, not three. So the two layers are the epiblast, the outer layer, and the inner layer called the hypoblast. Now this epiblast is going to then later form the ectoderm. Between the epiblast and hypoblast, it's going to form the mesoderm, and the hypoblast is going to form the endoderm. This was also asked to me, that's why I'm mentioning. So epiblast will form ectoderm, hypoblast forming the endoderm, and between the two, the mesoderm is formed. This hypoblast is all basically nothing but our yolk sac. So here, to answer this question, the primary germ layer endoderm is derived from the yolk sac, which is the hypoblast. Now in this diagram you can see very well, the one which is in yellow, the yellow shaded portion is our yolk sac, and you can see that this yolk sac is going to form the endoderm. And this endoderm is essentially going to be lining our yolk sac, whereas our ectoderm is going to be lining the light blue shaded part, that is the amniotic cavity. So don't get confused, just remember the two layers which later form the three layers, and the innermost layer or the yolk sac is going to form our endoderm. Now we all know our ectoderm is going to form linings of the nervous system, the skin appendages. Your mesoderm is going to form the lining of the cardiovascular system, the reproductive system, whereas your endoderm is going to form the epithelial lining of the GI tract, lungs, liver, pancreas, bladder, and all the other organs. So just remember the two layers, which layer forms what, and the hypoblast is nothing but our yolk sac, which is going to form the endoderm. So I hope that was clear. Okay, now the next question is, what do the lateral lingual swellings and tuberculum impa give rise to? Actually, this is a very easy question, but one student had a doubt between anterior 1/3 or anterior 2/3. Now remember, when the tongue is developing, if you've studied the embryo of the tongue, it's always divided into the anterior 2/3 and posterior 1/3. Just don't forget this. It's the anterior 2/3, which is the larger part of the tongue, as you can see in this diagram, the 2/3 portion, and the posterior 1/3. Now there are two lateral lingual swellings on either side, and one structure called the tuberculum impar in the center, and those three will fuse together and form the anterior 2/3 of the tongue. That is option B. Whereas there's another structure called the hypobranchial eminence, which has two parts, the cranial part and the caudal part. So this cranial part of the hypobranchial eminence is going to form the posterior 1/3 of the tongue, and the caudal part is going to form the glottis. So just remember, in my lecture on tongue also I've explained the embryology, but do not get confused between anterior 1/3 and anterior 2/3. So it's always divided into the 2/3 anterior and posterior 1/3. Now, one student asked, what does the philtrum and premaxilla develop from? Now, we all know in embryology there are basically 5 processes which are very important, starting with something called the frontonasal process and the maxillary process, 2 maxillary and 2 mandibular processes. So now we all know this frontonasal process is going to divide into 2 parts. The one in yellow, that is the medial nasal process, and the one in pink, the lateral nasal process. Now this maxillary process is going to grow medially or move medially. So for doing that, it has to fuse with the lateral and then with the medial nasal process. So that's how the fusion occurs, and they will grow and join in the midline. Similarly, your mandibular processes will also grow medially and fuse in the midline. So you can see here. Now along with this fusion, these two in yellow, that is the medial maxillary process on either side, will also have to fuse with each other in the center. And this symmetrical fusion is why we have the two halves of the body of the face which are totally symmetrical and equal. So this is because of this symmetrical fusion. So maxilla is going to fuse with lateral followed by medial, and our 2 medial nasal process will also join in the center. Once they join in the center, as you can see in diagram B, it is nothing but the intermaxillary process. It is called the intermaxillary because it is present exactly between the 2 maxillary processes. You can see here. Then this intermaxillary process basically is, since it's the fusion in the midline, definitely it's going to form the philtrum which is present in the midline, and the premaxilla, that is the a portion of maxilla with the 4 incisor teeth and the primary palate. To explain it better, you can see again the intermaxillary segment of the medial nasal process, which is seen in pink here. This is basically going to form this outer portion called the philtrum, and the inner part or the premaxilla also called the primary palate or the anterior most part of the palate. Whereas your maxillary process, which is seen in yellow on either side, they are going to be responsible for formation of the shelves of the palate or the plates of the palate called the secondary palate. So to make it sum it up, intermaxillary segment is formed by the fusion of the 2 medial nasal processes in the midline. It's going to give rise to the philtrum of the lip, the premaxillary part of maxilla which bears the upper 4 incisors, and the primary palate, which is the region of the hard palate just posterior to the upper incisor. So only this portion of the palate, this is the premaxilla up till the teeth, this portion of the palate called the primary palate, and the philtrum. All these 3 are going to develop from the intermaxillary segment. Now this was just a confusion regarding when the development of palate begins. So the answer was given as 4 weeks in one book and 6 weeks in the other, but from all the data I read, it's basically going to start at 6 weeks and end at the 9th week. So I think in this question 6 weeks will be the most appropriate answer, that development of palate begins at the age of 6 weeks and ends at 9. This is basically the critical period what I spoke about. So maybe that's why 4 weeks could also be like the initial formation could also begin at 4 weeks, and 6 weeks will mark the most important part of portion of the palate development, but still I would answer it as 6 weeks. Now a student was asking, what is cavernous sinus syndrome? Now basically you all know that the cavernous sinus is a paired dural venous sinus. It is a dural venous sinus which consists of a number of important structures which are passing through it. So we all know along the lateral wall of the sinus we have the trochlear nerve, the oculomotor, trochlear, and the maxillary, as well as the ophthalmic divisions of trigeminal nerve in that order: 3, 4, 5, 1 and 5, 2. And in the center of the sinus we have the abducens nerve and the internal carotid artery along with the plexus surrounding it. So basically if any of these structures can get damaged, it will be called cavernous sinus syndrome. So basically it is signs and symptoms resulting from compromise of 2 or more structures passing through the cavernous sinus. So any 2 or more than 2 structures, if they are involved due to any reason, then it will be called the cavernous sinus syndrome. For example, if your oculomotor nerve is involved, you know that it supplies the extrinsic muscles of the eye. So there will be proptosis and ophthalmoplegia. Ophthalmoplegia means weakness of the muscle. So the patient will have difficulty in the eye movements. He'll feel some amount of weakness. Then the trochlear nerve is going to cause vertical diplopia. You all know which muscles are supplied by these nerves. So then the abducens nerve, which is most commonly damaged in any cavernous sinus involvement, it will cause palsy of that particular nerve. Then you have the ophthalmic and maxillary nerves, which are sensory also and will cause upper face numbness. And Horner syndrome, which you all know is something caused due to involvement of multiple nerves in the cavernous sinus. So basically any two or more structures of the cavernous sinus which are present among these which I mentioned, if they are involved due to any etiology like neoplastic, like cancerous or vascular infections, or any inflammation due to any reason, if there are signs and symptoms related to involvement of two or more structures, then it will be called the cavernous sinus syndrome. So that's all it is. So you just need to have a good knowledge of the anatomy, the structures passing through it, and which, if each structure is involved, what could be the signs and symptoms. So you all know which muscle is supplied by which nerve. So you all know the oculomotor nerve supplies most of the important muscles of the eye. Then you have superior oblique supplied by trochlear nerve. So if it is damaged, then that muscle, the function of that particular muscle will be impaired. So superior oblique, for example, it will cause downward movement of the eye, so that will be impaired. Then you have the lateral rectus muscle, which is supplied by the abducens nerve. So the patient will be unable to abduct his eyes. So all of these signs and symptoms which will result due to damage will be called the cavernous sinus syndrome. All right. Now coming to the next one. So a student had asked me a doubt that the answer here is given as B in this question, in which all are true of mandibular nerve except, but the explanation was also given as D. Actually speaking, among these four statements, they have asked which one is false, right? All are true except. Both B and C are actually false. B, yes, obviously, because they've mentioned muscles of mastication are innervated by branches of the main trunk. Now, when we talk about the mandibular division of trigeminal nerve, the main trunk gives off the nerve to medial pterygoid only, but the other three masticatory muscles are given off by the anterior division. So not all muscles of mastication are innervated by main trunk. So yes, this one is false. Now option A, sensory branch arises from anterior trunk. Yes, that is correct. The buccal nerve, which is given off by the anterior division or the anterior trunk, is a sensory branch, so it is correct. Nerve to medial pterygoid arises from the main trunk, that is option C, is definitely correct here, you can see. Now option D is buccal nerve innervates buccinator. Actually this statement is also wrong. They have asked about the mandibular nerve. This buccal nerve, which is given by the anterior division of the mandibular nerve that you can see, this buccal nerve is sensory. It is not supplying the buccinator muscle. It is going to supply the skin over the cheek. So it's a sensory branch, that is, you can see here. This buccal nerve, which is given by the anterior division, is a sensory branch and it does not innervate buccinator. The buccal branch of the facial nerve is going to innervate buccinator. You all know the buccinator is going to be supplied by the facial nerve. You know the facial nerve also has 5 terminal branches. Among those, there's one branch, the buccal branch. That buccal branch of facial nerve is going to be supplying the buccinator, not the buccal branch of the mandibular nerve. So do not get confused in this. So technically speaking, both B and D are false statements, and hence in this question both of them could be the right answer. So I hope you understood my explanation of why these two statements are wrong. Now this MCQ was asked to me by a student saying the mandibular foramen is situated where? Now the student mentioned that the foramen should be situated at the level of the occlusal plane. Now keep this in mind. They have asked about primary teeth. Firstly, they are asking about a pediatric patient, technically, about primary teeth. Now we all know the mandibular foramen is a small opening, as you can see, which is present on the inner surface, that is the medial surface of the ramus of the mandible, wherein the inferior alveolar nerve will enter. So it's basically like a bony canal within the mandible. The nerve will enter through this and it will go as a canal throughout the mandible and finally end at the mental foramen. Now, in a adult, this foramen is usually situated around 7 millimeters above the occlusal plane. It can vary from patient to patient, but usually it is present about 7 millimeters above the occlusal plane in adults. But in children, it is actually present below the occlusal plane. That is the reason why when we are giving the inferior alveolar nerve block to anesthetize the inferior alveolar nerve, we have to be very careful that when we are passing the needle, it should be slightly low and more posteriorly than for adults. Always keep this in mind. It's a very important question. In a child, while giving the nerve block, our target is essentially that we want to anesthetize the nerve as it's entering the foramen. So we need to know the exact location of the foramen. So keep in mind that this foramen is present at a lower level than the occlusal plane in deciduous teeth. That's why when we are injecting the needle or when we are giving the block, we have to give it much more lower and more posteriorly than what we give in an adult. So always keep this in mind. This statement is very important. Now the next question is the most common malignant lesion of bone. Now the answer given is option D, and I was asked that why is it not osteosarcoma? Now just read every sentence of this question. They have asked the most common malignant lesion. They have not mentioned primary bony lesion. If they mention the most common primary lesion of bone, meaning that the lesion has started within the bone itself, the most common primary lesion of malignant lesion of bone is definitely osteosarcoma. You can see in this image, among the malignant lesions, osteosarcoma is the most common malignant primary bone lesion. So they have only spoken about bone lesions. But if they've asked the most common malignant lesion, then the most common one is a metastatic carcinoma, meaning the cancer has risen in some other organ and there is metastasis or spread from another organ into the bone. So that is most common malignancy of bone. When a patient comes, for example, with a malignancy or a spread or a lesion on the bone, in most of the cases they always do a full body scan and check that is there any cancer in any other organ of the body which has metastasized to the bone. So the most common one in that case is a metastatic carcinoma. But if they have asked within bone only, a primary malignant lesion of bone, then the answer would be osteosarcoma. I hope that was clear.